So I'll be talking a little bit about some work I've been doing that's ongoing, and this is in collaboration with Professor Anand in the School of Environmental Sciences, as well as another SES postdoc, Vadim Karateev, and Professor Chris Bao, who's in the school or the Faculty of Applied Mathematics at the University of Waterloo, where I did my PhD. So this modeling was kind of not something that we'd set out to do, prior to the beginning of 2020, but ended up being the thing that I pivoted to right after I finished my thesis, because there became a need for a lot more epidemiological modeling all of a sudden. So we'll talk a little bit about some background. I'm not a huge expert on COVID impacts in an environmental or animal health sense, but I do want to acknowledge that this is One Health. COVID has had impacts beyond just human health, in terms of wildlife trade, in terms of changes, environmental changes, increased medical waste, but also some positive outcomes in certain places during the lockdown, reduced greenhouse gas emissions, things like that. But I'm mostly going to be focusing on human health and specifically talking about the impacts of COVID-19 in Ontario. So those impacts have not been kind of uniformly distributed across the province, either in terms of regions. There's been a lot of cases in, for example, the GTA, and as well, the distribution of impacts has not been equal across ages. Obviously, depending on your age, the severity of your symptoms may vary, your mortality risk may vary, and due to a number of factors, including susceptibility and the types of jobs people have at different stages in their life, your chance of becoming infected does vary. So with this project, keeping those kinds of spatial and age-specific things in mind, we intended to build an age and spatially structured model for SARS-CoV-2 spread in Ontario. Where possible, we fit that model using Ontario-specific data. And what we're mostly using for right now is looking at the impact of non-pharmaceutical interventions over the past year. So things like closures and voluntary distancing, what was the impact of those, how many lives did we save, how many infections were prevented, and also looking at kind of a more granular level, what was the impact of individual people choosing to distance or not. So the model is pretty complicated. There's a lot under the hood, but I'll just briefly overview kind of the gist of it. So in terms of how we structure Ontario's population, we split it between the 49 census divisions. Within each of those census divisions, we split the population into different age classes. They're mainly 2-decade age classes. However, we just say with an 80+ category, it's obviously a small fraction of the population. And we allow individuals to travel between regions. So we get that idea that someone could travel from one region in the province to somewhere else and become infected or infect someone else there before returning home, to allow the kind of dispersion of cases from areas that have quite a lot of cases like the GTA. Now, the disease dynamics are pretty basic. We start out with people being susceptible. They can become exposed to SARS-CoV-2. From there, because we know that asymptomatic spread is an issue, people can become asymptomatic and infectious and then move into a removed category, I should say. Or they can go through this other path, which is exposed to pre-symptomatic, to symptomatic and infectious, and then into the removed category. For people who are not familiar with math epi type modeling, I'm messing up now even in saying this. Removed does not necessarily mean you've recovered. We're just using it to account for people who are no longer infectious. They may still have symptoms. For example, people with kind of long COVID symptoms may persist, but they're no longer in a position where they're transmitting the disease or the virus to others. Now, when we talk about transmission, this of course is happening because we're having these interactions with other people. Those interactions can occur in different spaces. So we kind of split everything off into workplaces, schools, homes, and other locations. And within those spaces, we're using age-specific contact rates. So the IJ terms here are for someone in age class I, how many contacts do they have in age class J? And this is so we can get a little bit more sophisticated information input into the model about your kind of interactions. For example, school-age children probably interact with a lot of other school-age children at school. They're not necessarily interacting with a lot of people over the age of 80 in a school, whereas perhaps in a home or another location, they would interact with more people that age there. And the data we're using here is empirical. So we do have Canada-specific data on these contact rates that we're inputting into the model. And the thing we now know is that, if we want to reduce transmission, we want to reduce contacts. And the ways that we can do this are by closing workplaces and schools and by encouraging people to voluntarily distance in their homes and other locations. So limit their contacts where possible. The work and school closures are fairly straightforward. You shut those spaces, you reduce people's contacts there. Whereas with the voluntary distancing, it's a lot harder to legislate what people are doing in their homes and other locations. So the way that we model that occurring is the idea that people can choose whether to do this or not. And the way that they gauge the extent to which they should be voluntarily distancing is based on their risk perception, where we assume the risk is based on the number of active cases in their region. So if there are a lot of active cases in my region, I go, I don't want to get COVID, so I'm going to be careful. I'm going to limit my contacts as much as possible. And we have this omega T on there, which is just a risk perception coefficient. And this functional form kind of saturates. So as active cases increase, you get a higher level of distancing. And that functional form agrees actually pretty well with data we have on voluntary distancing within the province. So you can see that we do have that kind of saturating function for voluntary distancing uptake as a function of the active cases in the population, and this is at a regional level. With this voluntary distancing uptake, we're using Google mobility data as a proxy there. So the extent to which people are less mobile in retail and recreation spaces is our proxy for voluntary distancing. So people choosing not to go to restaurants, choosing not to be in sporting facilities, things like that. So transmission, as we discussed, it depends quite a lot on your contacts. At the level of a single interaction on day T and region K in the model, your probability of becoming infected depends not only on that transmission probability, but also on your contacts and the extent to which you've reduced them, either through closures or through voluntary distancing. And as well, it depends on self-isolation. So we assume in the model that if someone tests positive for COVID, they reduce their contacts because they're self-isolating. So your risk of contracting SARS-CoV-2 from them is lower. Of course, these are very simple probabilities. Your probability of not becoming infected is 1 subtract that probability of infection. And we extend this out to say that across all your interactions on a specific day in a specific region, we can use a product to calculate your total probability of not becoming infected during any of your interactions. So 1 subtract that gives us your probability of becoming infected, which is what drives our transmission in the model. Oh, and I should note that these transmission rates are age-specific as well as region-specific, just to account for the fact that population density and behavioral differences and things like that in different regions, rural versus urban and so on, do impact transmission. So parameter estimation, where possible, of course, we try and take parameter values from the literature. However, in a lot of cases, that's not possible because this is a novel virus, and there are just a lot of things about disease spread that unless you're actually in a pandemic situation, it's really hard to, or epidemic even, it's really hard to estimate them. So the kind of one upside to, or not an upside to COVID, but a positive outcome has been the availability of a ton of very, very rich data. We have a lot of Public Health Ontario data that we're using to inform the model, daily confirmed cases broken down by age group at the provincial level, daily confirmed cases at the public health unit level, as well as estimates of the total cases to confirmed positive cases ratio at the province last spring. This is included in our fitting just because we know that at the time our testing capacity was much lower than it is now. So there are probably at the time a lot of cases that were not reported in our totals that were actually circulating in the population, particularly amongst people that would be asymptomatic that wouldn't have been tested at the time. And the final thing that we are incorporating in the model is, of course, that Google mobility data that we're using as our proxy for voluntary distancing. So given that we have this model, we did some fitting against all this data to try and figure out how reasonable our fits were with the model. And this is just an overview of the outcome of that fitting, which is that our breakdown by age is pretty good. We're kind of maybe a little bit off towards the beginning in that kind of March to May period of last year, particularly in the youngest and oldest age classes. In large part, probably this is because it's hard to decide on the kind of a functional form or the mechanism by which you understand that testing was working at that time in terms of who was being tested, what the kind of threshold to be tested was, and so on. And as well, the fact that our model is not explicitly accounting for congregate living spaces, so things like long-term care homes where there do tend to be outbreaks. We don't explicitly model that, so we're maybe missing some of those long-term care home outbreaks early on in the course of the pandemic, when we had kind of less information about COVID and less understanding of how to protect people in those living situations. So the other thing we have is, of course, this model is broken down by region, so we can look at what our regional fits are. There's 34 public health units, so I'm not presenting them all, but just for kind of regional local interest, we can look at our Waterloo and Guelph projections and see that the model of agreement there is pretty good. Overall, maybe not quite hitting that kind of December, January peak, but the overall trend is quite consistent. So given that we're reasonably confident that the model is tracking well on the cases, we can start to go back and explore some counterfactuals and consider what if things had been done differently. So the first thing we'll look at is what I'm going to refer to as the first wave, which is kind of March to August of last year. We can talk about the kind of initial choices that were made in the province, which were to close schools and workplaces, and also to encourage people to voluntarily distance in homes and other locations, try and stay home as much as possible, and so on. And we can see what would have happened if we kind of take out some of those non-pharmaceutical interventions. So here we're seeing what it looks like if we hadn't actually closed schools and workplaces, and you can see you get quite a high peak. Depending on the simulation, it can be very, very high. But overall, you see this trend of a peak in cases in kind of mid-May. And then, of course, they come back down because we've had quite a lot of transmission throughout the population. But for context, if we're talking about the number of cases we had around Christmas, it was kind of roughly in here. So imagining having that number of cases months ago when our ICU capacity had not been expanded, when we knew much less about COVID, the effects probably would have been quite drastic. And we can break down a little bit of what's happening there in terms of the different age classes to see that, as you might imagine, if you don't close workplaces and schools, the people that become infected are people who have a lot of contacts in those spaces, so working age people and school age children. And we do see that play out here. The cases per 100,000 population does come up quite substantially as soon as you open those spaces. But we do also see this bleed over into these older age classes because, of course, even if you're becoming infected in a school or a workplace, you still come home or you visit your grandparents or so on, and you do see transmission into those older age classes, even though they're not kind of directly impacted by those closures and openings. And that has, of course, a knock-on effect on the number of deaths. More cases mean more deaths, and particularly in these older age classes that have higher mortality rates, it becomes an issue. And that's something we really see play out if we look at a scenario where alternatively we do close workplaces and schools, however, we don't have the same kind of messaging about voluntary distancing. So if we assume that people, do whatever they want when they're not at work at school, they don't engage in voluntarily distancing. We see kind of two possible trends here. You can see kind of for ones that had prior to workplaces opening, which happens right about here, these ones with lower peaks, workplaces reopening, you do see kind of going from a plateau to increases kind of onwards into the fall. Whereas these ones where having no voluntary distancing had a really drastic impact on the number of cases, you basically just kind of had the virus burn through the population very quickly, and you see it come back down. Obviously, opening workplaces again causes a slight bump in new cases, but at that point, you've just had kind of a huge number of cases, a catastrophic impact on our healthcare capacity. And the interesting thing here is that it's that oldest age class that's hit really badly by this. Of course, everyone's impacted by not distancing in homes and other locations, but transmission becomes a particular concern for this oldest age class. And of course, necessarily you get a large number of deaths. So you can kind of think about, of course, workplace closures, school closures, and voluntary distancing are all important in keeping all of us safe, but voluntary distancing kind of particularly is important for keeping these vulnerable people who are elderly protected. So moving on into the fall, kind of our second wave, and we're just going to cut off at the end of December for simplicity. But looking at kind of the option that we had once we decided we were going to reopen things was whether we're putting restrictions in place when we do this. Do we have masking policies, things like that? And certainly different jurisdictions, particularly in the spring and summer, had different masking policies, different things like that. But we do kind of get more consistency in the fall when we start to reopen schools. And we can see what happens if those kind of restrictions hadn't been in place, where you see workplaces reopening here, and there's some increase in cases over the summer, and you see it start to really accelerate during the fall. Pardon me. Partially because you don't have those restrictions in place, partially because there is some evidence of kind of a seasonal component to SARS-CoV-2 transmission, and partially because, as I mentioned, people become fatigued with voluntarily distancing over time. So the longer we spend in this pandemic state, the people maybe become less risk averse, or the costs of continuing to distance outweigh the benefits of being able to kind of return to their normal set of contacts. So you see people distancing maybe less than they would have in March for the same number of active cases. And of course, you see increased transmission because of that. And it's a similar story in terms of opening and closing schools, having or not having measures in place when you reopen them does, again, have large impacts in these groups that have quite a lot of contacts in those areas, but then again, bleeding over into these older age classes. When people get infected in workplaces and schools and then come home and transmit in school or in homes and other locations. And kind of our final counterfactual in the fall, which is maybe pretty intuitive, but is still kind of an interesting thing to think about, is what if we just hadn't opened workplaces and schools and kept everything shut down all the way to the end of the year? We would have seen, of course, much lower case numbers, but you would still have had an increase in cases as time goes on, because as I mentioned, we have this idea of this behavioral fatigue. People not being able to sustain the level of voluntary distancing they were engaging in March and April all the way to December. And then you get into the Christmas period and people want to see their families, understandably so, and you get kind of this complex system of costs and benefits from distancing that come into play. And we can see here, unsurprisingly, keeping things shut kind of almost halves our number of deaths and reduces our cases. But there are, of course, a number of arguments made about how feasible doing this would have been and whether there's the political will to do it at all. So the final kind of counterfactual thing we looked at was, you recall these equations that we looked at earlier. What's underlined here is the way that the voluntary distancing works. And the assumption in that base model is that what you have is everyone is distancing to the same extent within a region. So every single individual in that population is distancing at, say, 60% for a given number of active cases. However, you can modify this to look at more individual level distancing decisions and say, well, some percentage of the population is going to choose to distance and reduce their contacts by that maximum amount once subtracted epsilon, and some percentage of the population is not distancing, whether that be because they are choosing not to, or whether perhaps there's someone that has a kind of living situation that doesn't make that feasible, a congregate living situation, someone who's unhoused, who doesn't have that option of being able to limit their contacts in those types of spaces. So you can go through and kind of slowly tweak these equations to get basically a case where you split the population into people who are compliant with voluntary distancing and not compliant with voluntary distancing. And then you can just kind of slide around and play with the percent of people in each group to see what the impact of that is. And of course, as I mentioned, we have this behavioral fatigue over time. So it's kind of not realistic to assume a constant number of people were distancing and were not distancing from March all the way to December. So we're just going to limit ourselves to looking at the first wave, kind of March to August, when it's a little bit more reasonable to assume a constant number of distancing individuals. And in doing so, we can look at our totals and try and get a rough estimate for how many people were distancing given this kind of structure of some subset distancing and some subset not, which is a little bit kind of coarse, but it is kind of a good place to start. These dotted lines that we're seeing move across horizontally here are the actual provincial totals, and where they intersect with these dashed and solid lines, which are mean and median values across all of our simulations, kind of gives us an estimate of what percentage of people were distancing during this March to August period. And you can see it's kind of roughly 60% maybe estimate based on cases and kind of 50th based on deaths. So we'll use that channel here as kind of our estimate for kind of roughly how many people we think we're distancing, kind of given the set of assumptions we've made about how that works. And we can look at something that's maybe a little bit more intuitive than totals, which is what is the median number of people additionally distancing? So people who are not distancing, if they had distanced instead, how many of those people would have needed to make a different choice to prevent one infection from occurring or to prevent one death from occurring? So our panel A here is to prevent one infection, and we see that in the range that we are, that kind of 50 to 60 range, it's a really small number of people, 5 to 15 people more distancing than there were could have prevented one infection. And even looking at deaths, which of course are a much lower probability event, we're still talking kind of 500 to 1,000 more people distancing would have prevented one death. And given that this is a province of over 14 million people, that's really a drop in the ocean. So you can see that these individual decisions do appear to have kind of a tangible impact on outcomes. And the one last thing we did, which is the only kind of projection thing that we've gotten into, is looking at some of the things with the new strains that are potentially coming in, specifically looking at the B117 variant out of the UK. This is kind of estimated to be 30 to 80% more transmissible, with the kind of estimate that we use being 50%, which aligns with the CDC's modeling in the States. But we can see kind of the effect of that being introduced into Ontario is quite stark, considering the way that the province is being reopened this month and next under the current provincial plan. So the blue line here with these, the blue is, I should say, solid is the median, and then these paler lines are just individual simulations. You can see that with that B117 strain present and dominant by mid-March, our cases come up really substantially under this reopening plan. And you can kind of see how the plan that's in place right now would make sense without B117, because that's what's shown with the orange line. If there's no B117 in the province, then reopening now is fine. But as soon as that B117 strain is circulating and it's more transmissible, you see cases come up really drastically. You get more cases by the end of March than we even had over Christmas when the entire province got locked down. So I guess it's going to be really interesting to see how this plays out over the coming weeks. Whether reopening places like Toronto and Peel gets pushed back even further, the extent to which B117 does actually become dominant in the province, and at what point in time. We're assuming right now by mid-March. If we're a little bit off, you could see, these lines be slightly higher or slightly lower, but it's undeniable that it's more transmissible, and that's a concern. We did also show one other scenario here, which is what if we don't reopen the province right now? And you can see that does kind of curtail the impacts of B117. But again, as with the fall, there are a lot of reasons beyond public health that is or is not going to happen or be considered viable by the province. So something to look at, but maybe not something that from a policy perspective is going to float. So just closing out, having shown you kind of all these different kind of backwards looking and forward looking things you can do with this model, I'll acknowledge that, of course, all models are wrong, but some are useful. This model has some limitations that we should keep in mind. The way that we're modeling closures and regulation in the model is ignoring things like the summer 2020 reopening phases, that phase 1, 2, and 3. We're just using phase 2, which is when the majority of places reopen, as our kind of proxy for that. And similarly, that color-coded response framework that went into play or came into play in the fall is not something we're modeling. We just have places be either open or shut in terms of their workplaces and school. Another thing that I think is interesting, but kind of currently hard to quantify the impact of, is the idea of case importation, particularly for regions of Ontario that border other provinces or border the states, and for places like Toronto that have major international airports that people are not necessarily quarantining when they arrive. But the idea of case importation being potentially a factor that's impacting the types of patterns we're seeing in terms of outbreaks is something we don't consider and would be cool to add in. As well, the way that we're talking about contact patterns is somewhat oversimplified. When we talk about interacting with the people in your region, we're just saying there's some kind of equal probability that you interact with everyone, whereas in reality, there's kind of more fine-grained spatial aspects to who you're interacting with, whether that be, oh, you live with a certain group of people, or you're probably interacting with kind of generally overlapping group of people if you go to the same grocery store every week, and so on. And additionally, the idea that contact duration matters, which is a thing that we don't account for, talking about kind of the way that close contacts are defined, and interacting with people where there's kind of that 15-minute bar on what is considered a close contact, or has been used as kind of a way to define that in the past. So the fact that we're not kind of treating differently an interaction with someone that you walk past in a grocery store and someone that you live with and sat on a couch to watch TV with last night is perhaps something that would impact model results. And the final thing, which is something that I mentioned earlier, so I won't talk about too much again, but the idea that we're not explicitly modeling congregate living settings, things like long-term care, places that you could see kind of higher rates of transmission. So given these limitations, of course, are something we'd like to address, but some other things that we're kind of interested in looking at with this are looking at dynamic individual distancing. So talked a lot about individual distancing choices, but the way that we set it up in the model and the results it showed are from a case where from March to August, if you were distancing at the beginning, you're distancing at the end. And likewise, if you are not distancing at the beginning, you're still not distancing at the end. But if, like, as I've said, there's a lot of kind of costs and payoffs to consider when people make decisions about distancing, both economic and kind of like intangibles, things that are harder to quantify, like mental health and kind of social pressures and things like that. So the idea of accounting for that and having a more dynamic system where people can shift their behavior in that individual level model would be really interesting to look at. The other thing, of course, the vaccination rollout is happening, not, I think, as fast as many people would like, but can use models like this to explore questions related to the vaccination, particularly because we have this age and spatially structured model. You can ask questions about vaccine distribution by public health unit, or who should be prioritized in terms of age groups, things like that, that are interesting questions to ask when we have these vaccines and we have a limited supply. And finally, the last thing to do is, given that you have sufficiently rich data, this is something that could be really easily applied to other geographical regions, whether that be other provinces and so on. Be interesting to see the extent to which it's generalizable. And with that, I will thank our funding sources, the Ministry of Colleges and Universities, and our EdCirc Alliance grant, and I'll open the floor for any questions.
Thank you so much, Dr. Fair. I just can't get over how much work also gets done in that, given the fact that, it was around this time last year that we really were starting to get concerned about COVID. See all of this sort of work that can be done is really quite remarkable. I just wanted to basically be here to sort of mind the questions. If anyone wants to, you can either unmute yourself or raise your hand or something like that, or ask questions in the chat as well, and I'm happy to read those out. And there's one right now from Pete that says, has any of your modeling data been shared with the local Wellington, Guelph, Dufferin Health Unit or Public Health Ontario?
So we are not kind of affiliated with anyone in any of the public health units we've done. So we have kind of spoken with people, but no one in public health. I'd certainly be interested to do it, because we do with this kind of regional model or region-specific model, you can look at region-specific projections for things like B117.
Hey, Kat, it's Jane. Maybe I can jump in with a question. I actually think I have two, but I'll start with one in case other people have questions. One is, have you played with different scenarios in terms of the B117 and the other new variants about just delaying reopening by a week or two, and how that affects the projected case counts going forward?
Yeah, so we actually, I didn't include it in here because you just end up with a lot of lines, but we have looked at kind of scenarios where you do just have, the initial plan on, I think the February 9th plan was that kind of 6-day, three phase staggered reopening. And of course, they've now pushed back some regions because places like Toronto don't have it under control. But yeah, you can play with scenarios where you just create larger gaps between those 3 or 4 phases. And particularly because we know that someplace like Toronto or Peel is responsible for a lot of cases in the province. If you want to keep those provincial totals down, what you do is keep those places shut. And so I don't have the projections here, but yeah, you can see that, the longer you keep everything shut, and particularly those regions that are kind of responsible for a large proportion of cases, the further you can push back that blue line coming back up. And that's kind of an interesting thing to talk about in terms of the vaccine rollout, because our model right now doesn't have vaccination included in it because not very many people have been vaccinated. But if you can buy yourself time by leaving places closed for longer, then, and you can get yourself together with your vaccines, then you have kind of this way of attacking from multiple points, from vaccination, from these non-pharmaceutical interventions, and things start to look more positive for sure.
Cool, thanks. And if no one has a question, maybe I'll jump in with my second one. And it's more just thinking about whether you or others have looked at using the closures, I guess, and modeling other health outcomes. So while we may be sort of able to control the spread of SARS-CoV-2 and some of the variants, what are we doing in terms of mental health or some of those other health consequences, and how do they balance out, I guess?
Yeah, I think that's a really kind of interesting question. I think it's really hard to model because so much of that is kind of intangible. I'm not familiar with anyone doing any kind of modeling particularly with that, but I have seen certainly some people that oh my gosh, I can't remember his name now. There's a guy who does like public health research related to addiction in the UK that I've seen posting kind of interesting stuff on Twitter, looking at excess mortality, where you can break it down by, well, this is excess mortality where these are COVID deaths, but also mental health impacts and things like that. Talking about, particularly in the context of addiction and things like alcohol abuse and deaths and outcomes related to that, and looking at that over time and saying that, yeah, in the UK, you can piece that out and see that there are these kind of knock-on effects for mental health and for health outcomes related to that. Yeah, I guess it would be cool to model, but any modeling involving humans is just really difficult because you can't actually assume we're rational actors, even as much as economists maybe would like.
No, I totally appreciate it's difficult. I just think it sort of gets to that, maybe more of some of the One Health aspects or the different health aspects and sort of those, whether they're intended or unintended consequences of some of our decisions, and how do we balance those out? Yeah,
I think it's even in terms of talking about like straight on the healthcare system, right? As soon as your ICU is full of people who have COVID, it's not got other people in it. As you have to start pushing back surgeries that are not super pressing and things like that, that is affecting people's quality of life, simply because we're straining our healthcare capacity. So,
yeah, great, thank you. I really enjoyed your presentation.
Oh, thank you.
If no one else has a question right now, I was also curious about some of those geographical or environmental pieces, I guess, and wondering about, yeah, how much different that modeling would look in a place like Toronto or Peel compared to maybe a remote Indigenous community or a smaller, even I think about like Sault Ste. Marie. I have family there, and how they're reopening and sort of what seems to be normal for them looks so different than what it does for us. And so I guess wondering, you may have touched on it, but did you have to create those or did you create those graphs and models for like each region? Or was that something that kind of like you're focusing maybe on local areas right now and then could apply that model to a more region specific question, I guess?
So yeah, we do have projections, like the 117 projections for every public health unit in the province, and we have fits for every public health unit in the province. Yeah, it's horrible to try to graph 34 of them on a slide, but yeah, they do exist, and it's certainly interesting to see how well or poorly the model fits in certain places. It tends to be harder to get accurate projections for places that have low populations because stochasticity or randomness becomes such a larger factor when there are so few people interacting. Whereas if you're, in Toronto or someplace like that, where it's very population dense, you can imagine it's like having a larger sample size. You can kind of get a better gauge of what's going on. Whereas in a place, a remote community, all sorts of things come into play in terms of, well, maybe there's not very many people, but if there's only one grocery store and everyone's always in that grocery store, like thinking of, like, I'm from rural Alberta, and yeah, the COVID reality of rural Alberta is not the same as it is even in KW, and which I'm sure even feels very different to Toronto right now. And it's kind of interesting, but really complicated to think about the ways in which some of that is simply due to population density, but some of that is due to behavioral differences, all sorts of kind of socioeconomic things that would differ between communities, whether that be affluence, the types of jobs people have, how dense their like living situation is, like apartments versus detached homes, versus where I'm from, which is our nearest neighbor is 2 kilometers away. Like you don't have to see them unless you don't want to, right? So certainly an interesting challenge to try and get something that kind of works reasonably well across that range of situations.
Yeah, definitely. I feel like all anytime anyone's really doing this insane mathematical modeling, I'm just sitting in awe at all of it. So I'm like you said, it would be a difficult thing to try to, especially model, yeah, human interactions and things, because like you said, there's already so much variability just within each individual, let alone region.
Yeah,
Pete has added another question too that says, have you had any difficulties getting the empirical data?
Yeah, I mean, I hate to complain because this is so much more data than I have for any other project that I work on. For example, the last thing I was doing was doing some kind of climate change modeling in Brazil, and yeah, that it's like non-existent compared to this, compared to the level of data we have, the detail, and the fact that you can just go download it off a website instead of having to email someone begging for it. Certainly there's some, I've run across a couple times things that I can tell that Public Health Ontario has because of the data that they're presenting in their graphs or in the weekly reports they have that isn't publicly available. And I thought, oh, maybe I'd like to have that, but you know, you have to ask them for it, and it's a whole thing. So we kind of make do right now, because this is obviously a scenario where we want to have a good model, but we want to have a model that's fast, right? We want to have something that's ready, because it doesn't matter what we think about B117 if we're presenting projections in August of this year as opposed to now. Like, it's too late at that point. I think the biggest data availability thing is probably that voluntary distancing, that Google mobility data that we have, because first of all, it's coming from Google. You have no understanding really of how they're putting it together. You don't know what the demographics are of the smartphone users. Like, you would imagine that the mobility patterns of an 80-plus-year-old might not be captured by Google mobility data, because you're not sure that that person has a smartphone. And you're also not sure kind of, you know, when they say that these calculations are compared to baseline, and then, you know, you have so many questions about how it works. And obviously there's privacy reasons not to release this.
Yeah, we have another question from John that says, did you account for the underreporting and undertesting?
Yeah, so we did try and do that. So the way that testing works in our model is we start out with some very low kind of initial testing rate last March, and then it ramps up over time. And we also have modifications so that testing rates differ by age. For example, children tend to be more asymptomatic, and also not to experience, or children are more often asymptomatic, I should say, and also don't tend to experience quite as many severe symptoms. So, you know, it's probably true that we're testing kids less, partially because we're not as concerned about them, but also because it's less likely that they're going to show symptoms that would cause us to go, oh, like, I should take my kid to go get tested. Of course, some of that's changing now that they're doing in-school testing. But we certainly are trying to account for the fact that there is variability in testing by age, and also based on whether you're symptomatic or not. Because you imagine, particularly early on, when I'm thinking I had to go get a COVID test in June, and before I went, I had to check, okay, well, am I meeting this certain set of requirements that allows me to get this test? And that kind of relaxed in the fall, the restrictions on it. And then I think end of November, they again changed the guidelines of kind of what bar you have to meet to get tested. So it's certainly a thing that we're trying to account for. But yeah, there are a lot of things that contribute to who gets tested in a demographic sense that are kind of, you do your best to control for, but you're probably still missing some of it.
Excellent, thank you. Jane, did you have another question?
I did, if we have a second. I
was just going to say last call for questions. So
thanks, Anna. I was just really intrigued with the slide you had about sort of like if 15 more people did the distancing, then it would prevent one infection or something to that effect. And I think that's messaging that maybe I haven't seen a lot of, is that individual actions can make a difference. And I think that's a really tough public health challenge, because we don't see the effect of our own decisions to stay home that day. And I was wondering if you had any traction or uptake on this information in terms of encouraging people to do certain behaviors.
So yeah, this is definitely like that was kind of the idea of finding a way to quantify this was a thing that was what was driving us to do that kind of the things that are shown in that slide, is because yeah, like I think from a messaging perspective, if you can say, look, like if you and 14 of your closest friends like keep it together for another 3 months, then
yeah, one
person doesn't get sick now. And this is something that, you know, obviously this model's like I discussed the ways in which it's kind of not 100% realistic, because they never will be. But yeah, it's kind of like an interesting thing to try and quantify, and that you can do with this type of model that you can't necessarily do with other models that kind of work at a population level. So yeah.
Yeah, and I think it's something that maybe we should do more of, is just to demonstrate that our actions do matter, and you know what you choose to do, what you choose to buy, who, I don't know, whatever. It can have an influence, because it's hard to see that effect often.
Yeah, for sure. It's a thing that like my one collaborator, well, I guess both my collaborators, this is a thing that we talk a lot about in terms of climate change, in terms of epidemiology and things, that human behavior has impact on environmental systems and animal systems. Like everything is interconnected, so of course there are consequences. But yeah, it's interesting to try and kind of drill down into, like, you specifically, what is the kind of tangible outcome of you doing something or not doing something.
I might pick your brain about that later.
For sure. Sounds good.
Okay, thank you. That's it for me, really.
Oh, thanks for the questions. They were great.
Thank you so much, Kat. We hope to see people in a few weeks, and thank you for your time.
Yeah, thanks for having me.